first brain CT was performed to rule out intracranial pathology. However, the interesting finding here is in the orbit. Before looking at the abnormal side, let's talk a little bit about the normal right side. This is the orbital globe, and this here, which is normally hyperdense, is a normal lens. This is the cornea, and the fluid between the cornea and the lens is the anterior chamber. The fluid-filled space behind the lens is called the vitreous, and this is called the vitreous fluid. This here is a normal optic nerve connecting to the globe. These two foci of calcifications are not seen in all patients. In fact, this is part of an aging process. These are called normal, senile, or aging scleral calcifications. Now, what you don't see on a CT scan are the three normal layers that we know from our basic anatomy. From inside out, you should have the retina, followed by the choroid, followed by the sclera. It is important to remember that the retina, which is the inner layer, terminates by connecting on each side of the globe to something called the ora serrata. On an axial image, the ora serrata is located at 10 and 2 o'clock positions. When you have detachment of the retina or detachment of the choroid from various causes, you're going to have bleeding beneath that membrane. Such detachment would present itself as hyperdense material within the vitreous fluid. If this were to be retinal detachment, we know the retina should not extend beyond the ora serrata anteriorly, while hemorrhage from choroidal detachment would extend all the way anteriorly. Knowing these facts, let's look at the abnormal orbit on the left side. The first thing you notice is that you don't have the normal lens, it's absent, and that's related to cataract surgery. The second observation is seeing the normal senile scleral calcifications, similar to what we saw on the other side. Now, what's more important, if you look carefully, you'll notice this hyperdense material in the posterior globe. High density is consistent with blood. It's very important to notice this well-defined V-shaped configuration that does not extend beyond 2 or 10 o'clock. This tells us that this bleed is underneath a membrane that's confined by the ora serrata, which is the retina. So V-shaped appearance confined by the ora serrata at 2 and 10 o'clock is consistent with retinal detachment. Another difference is that the retina extends all the way to the insertion of the optic nerve, and that's why this abnormality is converging towards the optic nerve insertion. This is in comparison to detachment of the choroid, where the abnormality is away or divergent from the optic nerve insertion. So we quickly discussed the appearance of the normal hyperdense lens with the anterior chamber and the vitreous fluid, in addition to senile calcifications of the sclera. We understood the retina is confined by the ora serrata at 10 and 2 o'clock anteriorly, and that's why retinal detachment would have a V-shaped appearance. Another difference between retinal and choroid detachment is that retinal detachment would converge towards the optic insertion. Also remember that the absence of the lens should not confuse you, since this is a common post-surgical appearance. So, interesting orbital pathology could be seen on a normal CT scan. Hoping to show you more cases in the future. Thanks. This is a chest radiograph on a 46-year-old female patient who presents with mild shortness of breath. The first thing we notice is the presence of bilateral heterogeneous lung opacities. Looking into the opacities with more detail, you'll notice that the opacities do not look like consolidations or ground glass. By that, we mean the opacities do not have the airspace or alveolar appearance that is classically seen with pneumonia, for example. Instead, looking carefully at the opacities, you'll notice that these are composed of lines and nodules. If they look like lines, we call these reticular opacities. If they look like dots, we call these nodular opacities. And if you see both as what we see here, you're going to call this a reticulonodular pattern. So if you see reticular, nodular, or reticulonodular opacities, you're talking about interstitial lung disease. Now, once you see interstitial opacities, it is important for you as a radiology resident to decide if the opacities are smooth or coarse. In this case, you probably have decided that the opacities are coarse. If you think you're looking at a coarse interstitial pattern, the two big possibilities would be that of fibrosis or bronchial wall thickening. Now, once you see interstitial lung disease that may represent fibrosis, you have to decide if the abnormality predominates in the upper versus lower lungs. Looking at this case, you probably have decided that the opacities are more predominant in the upper lung versus less involvement in the lower lungs. For an experienced eye, you might have noticed as well that both hyla are slightly elevated, which tells you that this is a fibrotic process. The retrosternal area should be dark, and this is not the case here, which confirms the presence of these reticulonodular opacities. So what's your differential diagnosis for upper lung predominant, interstitial, and likely fibrotic disease? Remote infections, in particular granulomatous infections such as TB, or fungal infections such as histoplasmosis is a cause. Non-infectious granulomatous causes such as sarcoidosis is also important. If the patient has an occupational history, occupational lung disease such as silicosis might cause that as well. Chronic hypersensitivity pneumonitis from organic or non-organic material could cause fibrosis. Radiation could induce fibrosis in the long run. An example would be patients with lymphoma receiving radiation to the neck region. In a small percentage of patients with rejection of a lung transplant, upper lung fibrosis may occur. Autoimmune disorders such as ankylosing spondylitis are also associated with such a finding, although this is very rare. This is the CT scan on the same patient. As suspected on the chest radiograph, the abnormalities are clearly upper lung predominant, with relative sparing of the lower lungs. Now let's try to dissect the findings. The first thing is that there are areas of irregular septal thickening, which is consistent with reticulation. Reticulation means fibrosis, and what supports that is the architectural distortion and the mild associated traction dilatation of the airways. Now, if you look at other areas, you'll notice that you have lots of tiny irregular nodules. The nodules are distributed along the pleura, as you see here peripherally. They also involve the septations or the interlobular septae of the secondary pulmonary lobule, such as these lines. If you concentrate on the fissure here, you'll notice that it looks nodular. So many of these nodules are fissural in distribution as well. Although not so pronounced in this case, some of the nodules surround the peribronchovascular structures. Please note that all those locations that we just described are where lymphatics of the lungs live, and this is what we call a Pier lymphatic distribution. So a Pier lymphatic distribution is composed of peribronchovascular, septal, fissural, or subpleural locations. If you think about an upper lung predominant disease that could be fibrotic and has a Pier lymphatic component, that would give you a diagnosis of sarcoidosis. So sarcoidosis makes lots of sense in this case, especially that this is one of the diseases that might look striking on imaging with a relatively normal patient. We learned lots of things from this case. First, that interstitial opacities could be reticular, nodular, or reticulonodular, and this is different than alveolar opacities. Second, if you suspect an interstitial opacity, decide if it's smooth or coarse. If it's coarse, fibrosis is a very good possibility. Third, once you see diffuse lung disease, especially interstitial lung disease, decide if it's upper versus lower lung predominant. Fourth, if you're not sure of the diagnosis, look at the retrosternal area. That's a good location to look for lines and dots or interstitial lung disease. We also learned the differential diagnosis of upper lung disease, which includes tuberculosis, histoplasmosis, silicosis, sarcoidosis, hypersensitivity pneumonitis, radiation pneumonitis, ankylosing spondylitis, and rejection. We learned as well that irregular septal thickening is equal to fibrosis, and that's what we call a reticular pattern on CT. We also learned that the Pier lymphatic distribution is that of the Pier bronchovascular, fissural, septal, and subpleural locations. And finally, an upper lung predominant, fibrotic, Pier lymphatic disease is typically sarcoidosis. Thanks for watching. Today's case is a quick show and tell case. Although the case is about a cardiac finding, it's something that you could commonly see on chest CTs. For the sake of orientation, this is your left ventricle, this is the right ventricle, this is the left atrium, and this is a distorted right atrium. Now it's clear that you have this low density lesion in between the left and right atrium. The density of this abnormality is equal to that of subcutaneous fat, so it's a fat abnormality. Location is in between the left and right atrium, as we said, and this is the location of the interatrial septum. So this is a fat abnormality that replaces the interatrial septum, and it's called lipomatous hypertrophy of the interatrial septum. For more senior residents, please note this extension into the right atrium. This is the location of the crista terminalis. So, lipomatous hypertrophy of the interatrial septum may be very pronounced, and it could even extend into the crista terminalis, mimicking a tumor if you don't know it. This could appear very confusing on echocardiography, and it's a very easy diagnosis by noticing the density on a CT scan. It could even look more concerning on a PET scan, where you might see metabolic activity, mimicking tumor. Imagine the clinical scenario. Lots of cases in PET scanning are done for neoplastic disease, and this could be very confusing if it's of high uptake. The reason fat would be positive on PET scanning is that sometimes this is composed of brown fat, which is an active form of fat that has metabolic activity. To conclude, lipomatous hypertrophy of the interatrial septum is replacement of the interatrial septum by fat, which could extend into the crista terminalis. This appearance may be very confusing on echocardiography and may be mistaken for a mass, and even sometimes more confusing on PET scanning if it's brown fat. Good news though, it's an easy diagnosis on CT scan by noticing the fat density and the classic location. Thanks for watching. Now, since the patient fell down, you should treat this as a trauma case. Have you noticed anything? There are several things that you could look for on a trauma case. This is showing one of them, which is actually a bone abnormality. In many ways, bones are considered hidden areas on a chest radiograph. That's why you have to look at them carefully. Knowing that, have you seen the finding? If you didn't yet, we're going to see another image to make it easy. This is a slightly oblique view of the left ribs, and the findings that I want you to see are much easier appreciated here. Look at the normal rib, which has normal cortex that is not disrupted or displaced, compared to these ribs here. As you can see, the cortex, superiorly and inferiorly, is disrupted, and the two bone fragments are displaced. So here you have multiple ribs with displaced fractures. Let's go back to the standard chest radiograph where it's more difficult to appreciate. Now let's enlarge the area of interest on the chest radiograph. It's easier now to appreciate the same abnormality. This was a quick case of trauma that demonstrates that bone abnormalities may be difficult to pick on a standard chest radiograph, so you have to look carefully. If you're suspecting rib fractures, dedicated frontal and oblique rib views may help you detect minimally displaced fractures. So always check the bones on chest radiographs. Thanks for watching. Your comments are appreciated as usual.